appreciate you being here. If you can get that mic, pull that mic in front of you. Whatever the way is most comfortable. As long as you keep that in front of you, we'll be able to make a good record and we'll all be able to hear.
Okay.
Counsel.
If you could please state and spell your name for the record.
It's Kacee DeSalvo, KELSEYDESALVO.
What is your profession?
I am a endocrinologist.
What is an endocrinologist?
Endocrinologist is a physician that specializes in hormones and how they work in the body, including diabetes.
Okay. I'll get to that in a second, but I want to talk just briefly about your educational background. You mentioned that an endocrinologist is a physician. I guess briefly describe your education.
Sure. So I did undergraduate at University of Colorado. Then I did medical school at the University of Colorado, which is 4 years. Then we do internal medicine residency for 3 years. That was also at the University of Colorado, followed by a 2-year endocrinology fellowship where we go into the hospital.
How long have you been a doctor?
I've been an MD since graduating medical school, but a board certified physician happened when I took my boards after my internal medicine residency. I was board certified in internal medicine. And then after endocrinology fellowship, I was board certified in endocrinology, diabetes, and metabolism.
And how long have you been board certified in endocrinology?
Since 2019.
You mentioned that endocrinology deals with the I forget what word you, but treatment of hormones?
Yes.
What types of hormones?
Oh, there's so many different hormones in the body, but we kind of divvied up into pituitary hormones, thyroid hormones, adrenal hormones, and then in the pancreas, there's insulin and glucagon. So there's lots of different glands in the body that make hormones, that those hormones act on other organs.
I'm going to be talking with you today about insulin. I believe you mentioned that diabetes is something that you treat.
Yes.
What is diabetes?
So there's sorry, I'm just making sure the mic here. So there's 2 different forms primarily of diabetes. There's type 1 diabetes and there's type 2 diabetes. Type 1 diabetes is where something of your immune system attacks the pancreas and the pancreas is no longer able to produce insulin. Type 2 diabetes is where the pancreas is still producing insulin, but the cells are resistant to that insulin action. They don't want to take up sugar from the blood. And so there's 2 different kinds.
And it sounds like the hormone primarily associated with diabetes is insulin.
Correct.
What is hypoglycemia?
So medically defined hypoglycemia, there's 2 definitions. One is a serum blood sugar less than 55 if someone is having symptoms consistent with hypoglycemia, less than 45 if someone is not having any symptoms of hypoglycemia.
Is hypoglycemia something in addition to diabetes that you treat in patients?
Yes, so I probably see a patient who has hypoglycemia every single day in my clinical practice, and that is because I see a lot of patients with diabetes who are using insulin, and if they dose too much insulin, they can have problems with hypoglycemia.
All right, I'm going to come back to that. I want to cover a few, basic items first. The jury's heard a lot about different types of syringes. Is there a particular type of syringe that's used with insulin?
Yes, typically they come in 1 ml insulin syringes or 0.3 ml insulin syringes, and they have units on them. So when we talk to patients about how to administer insulin, we often talk about how many units of insulin they should be administering. So for instance, I might say you should administer 5 units for insulin to cover your breakfast. So they would pull out an insulin syringe if they don't have an insulin pen, and they would draw up 5 units. So in the syringe, it's units instead of milliliters that we would normally see in another syringe that would fill with a different medication.
Is there something different about the needle with insulin syringes, or unique or particular?
No, the needles themselves come in different sizes, so different people have different amounts of subcutaneous tissue, so we can order different size needles that go onto those syringes. So someone who's really doesn't have a lot of fat on their skin would use a really small needle, just like our pediatrics or kiddos. But then if other people need a little bit longer syringes, needle sizes, not syringes.
Are you familiar with syringes that may be used, for example, to administer saline into a port in somebody?
Yes, they often come in flushes, like saline flushes. They're often that's what we call them. They're in a syringe and they're prepackaged. So the nurses just there's lure locks on them and they can just insert it onto a needle and then push the saline through. Those are usually in milliliters.
How is a flush different than an insulin syringe?
Which I could show you. Insulin syringes are very, very skinny and they're very small because it doesn't take very much insulin to give a big dose of it. So they are significantly smaller than saline flushes.
I'm going to jump around a bit. You mentioned your education and training, particularly as a medical doctor. Do you know what a DNR means?
Yes, DNR means do not resuscitate. So if a patient, sometimes we say is coding, that means that their heart stops, that they don't want the medical team to come in and perform CPR. CPR is mechanical pressure on the heart to try to make the heart pump blood. And with a do not resuscitate, when you're running a code, we put shock pads on patients' chests to deliver shocks to see if we can restart the heart with electrical activity. And then there's other medicines that we would give in the case of running a code. So a do not resuscitate means that in the event that the heart stops, you do not want those particular interventions.
In your training and experience, does a DNR mean that if somebody is in a clear medical crisis, you cannot touch them at all or give them any medical care?
So absolutely not. Someone can have a do not resuscitate. We can hospitalize them, for instance, and they can be having an asthma exacerbation, and we can give them nebulizers, or they can be in diabetic ketoacidosis, and they can get insulin. Or they can have pneumonia, and we can give them antibiotics. Do not resuscitate just really means in that moment, if their heart stops beating, that they do not want us to intervene.
Do you work with nurses in your practice?
I do work with nurses in my practice.
As part of your practice in working with nurses, do you have to have some familiarity or knowledge about what nurses would know?
Yes.
Would you expect a nurse to know what a DNR means?
Yes.
You said you work with hypoglycemic patients at least every day. Is that fair to your testimony?
Yes.
Do you test blood sugar often in your line of work?
Yes, so most of my patients have continuous glucose monitors, which are little sensors that sit under the skin, and they will measure blood sugars every 5 minutes. So that is typically how I'm looking at blood sugars, is from these sensors that patients are wearing every single day, and we get these downloads. Now, some patients don't want to wear a continuous glucose monitor, and so they will prick their finger using a standard glucose meter, which is where they use a lancet and they get a little drop of blood, and then there's a meter that has a testing strip, and the blood you put it onto the testing strip and it goes into the meter, and the meter will read the amount of glucose inside that blood sample.
So you've certainly done that type of testing with the pricking of the finger and using a glucometer.
Yes.
When you're doing that type of testing, do you wear gloves?
Yes.
Do nurses that work with you do that type of testing on patients?
Yes.
When they're doing that type of testing with pricking fingers, do they wear gloves?
Yes.
And why is that?
Because you're dealing with someone else's bodily fluids, and there could potentially be infection risk. So you want to always make sure as a healthcare worker you're protecting yourself as well. So we recommend when you're dealing with someone else's bodily fluids that you wear gloves.
We talked about your treatment of patients with diabetes and hypoglycemia. Have you ever dealt with patients with insulin overdoses?
Yes.
Now, you've been retained as an expert in this case by the state of Utah, is that right?
Yes.
And you've reviewed certain items relevant to the case?
Yes.
What have you reviewed in this case?
So I have reviewed the hospital records from when Kacee was admitted to the hospital. I have reviewed a PDF of blood sugars, including the time that those blood sugars were taken and those values. And I have reviewed a preliminary hearing transcript. Those are the documents that I've reviewed.
Okay, and talking about a preliminary hearing transcript, that's a prior hearing that occurred in this case. Do you remember whose testimony you reviewed?
Yes, there was a medical examiner, and then there was the primary care physician who was treating her in the outpatient setting.
You were not given to review text messages,
Correct. I have not reviewed text messages.
police reports.
No.
You've not been given to review consultations with potential other witnesses or other experts that may be involved in the case.
I have not.
Do you feel like, well, actually, I'll get to that in a second. The jury has heard quite a bit from a bunch of different witnesses already about insulin, and so I'll try to keep this brief. And I know that you're the insulin expert, so as
Objection as to characterizing who's what capacity at this trial. Just wonder if the state could just ask for questions.
sure.
I'll sustain the objection. Let's move on.
I was just going to say that we'll try to keep it brief. So to the ability you're able to do that. And you've kind of already described in type 1 diabetes versus type 2, but briefly tell us what insulin does.
Okay, so insulin is made by the pancreas. It gets secreted and it travels to every single tissue in the body, and it helps those cells take up blood sugar or sugar that's in the blood, so your body can use that later for fuel. So it puts sugar into muscles and into fat. If you believe it or not, there's only 1 teaspoon of sugar actually floating around everyone's blood. And so when you eat something that's really high in sugar, or carbohydrates is another word we use, your body has to have a way to put that sugar into muscle or into fat so you can use it later for energy. And insulin is the key that kind of unlocks those cells that allows glucose to move from the blood into that tissue.
Is insulin necessary in some form in the human body for it to function?
Yes.
Is there, I guess, what is endogenous insulin?
Endogenous insulin is insulin that is made by the pancreas, and it is secreted as something called proinsulin, which has a C-peptide chain attached to the actual active insulin molecule. And when it gets released, the C-peptide gets cleaved from the insulin, and that activates the insulin, so then it can go to every single tissue to try to get glucose into those cells.
So endogenous, fair to say that's created by your own body?
Yes, endogenous means created by your own tissue, by your own self. Exogenous insulin means insulin that was produced by a pharmaceutical company. It's chemicals, molecules that are very structurally similar to endogenous insulin but different. And those are insulins that we can give by injections.
And maybe we already covered this, or it may be obvious, but in what circumstances would someone need exogenous insulin?
So people with type 1 diabetes need both a long-acting insulin and a short-acting insulin. Sometimes long-acting insulin we call basal insulin. And there's many patients with type 2 diabetes where their body still produces insulin, but their tissues have such a degree of insulin resistance. You need more insulin to kind of help those cells kind of open up those doors to allow glucose to go in. So there's a lot of patients with type 2 diabetes who also need to be on insulin products.
If a patient is not diabetic at all, and their body is producing endogenous insulin normally, would they have any need for exogenous insulin?
Absolutely not.
What might happen if a non-diabetic patient receives exogenous insulin?
So that insulin would be absorbed by the body, go into the bloodstream, and then it would start acting like endogenous insulin. It would start telling those cells to pull glucose out of the blood. And if that's an inappropriate release or use of insulin, the blood sugar is going to start to drop because your body didn't need that extra insulin. So blood sugars will be low, and that is hypoglycemia.
Is hypoglycemia dangerous?
Yes, so hypoglycemia can be fatal.
In what circumstances?
So the most important tissue that you have that's really sensitive to hypoglycemia is your brain. So your brain relies on glucose coming in from the blood in order for it to function. And if you don't get enough glucose, your brain cells start to die. And there's something in your brain stem that tells your body to breathe. And so if those parts of your brain start starving because they don't have glucose, they start dying, they can no longer tell your body to breathe. And so then oxygen levels will start to drop because you're not taking big breaths, you're not able to get oxygen to your cells.
You mentioned the brain. Are other organs in the body, does hypoglycemia affect other organs in the body?
Yes, every single tissue needs glucose to basically have those cells stay alive. So the heart, the kidneys, the liver. But the brain is very sensitive because unlike the liver actually can store glycogen, which is, it can break it down into sugar, the brain doesn't have a way to store sugar. It's totally reliant on the rest of the body delivering sugar and via the bloodstream.
Is the amount of time that a patient may present with hypoglycemia important?
Yes, so if you start to have low blood sugar, hypoglycemia, the sooner you intervene, the less likely you are to have long-term neurological damage or damage to your brain cells. So if you correct that very quickly, people can go back to their normal baseline. However, if their brain is starving glucose for hours, then we often see cognitive deficits where people don't recover back to their baseline. They can't think like they used to. And certainly if there's hypoglycemia that can precipitate a seizure, that is very damaging to the brain tissue.
So it sounds like hypoglycemia can reach a point where, fair to say, irreversible brain damage.
Yes, you can get irreversible brain damage from hypoglycemia.
Can it also be fatal?
Yes. So at some point, your brain will no longer have enough sugar and it will start to shut down, and then your lungs don't get the message to take in deep breaths. And when that happens, oxygen levels start to fall, and every single tissue in the body will start to die because every tissue needs oxygen.
As blood sugar drops in a person, what symptoms do you typically see?
So there's two types of symptoms that people can get from hypoglycemia. The first is symptoms related to adrenaline release or epinephrine release. So your body tries to correct the hypoglycemia by secreting a lot of epinephrine. And so epinephrine makes people really hot, really sweaty. It can make their heart start beating really fast. They can start to feel anxious. That's kind of like a stress response to the hypoglycemia. The other symptoms are the brain's response of not getting glucose, which is slurred speech, confusion. Sometimes people almost seem like they're drunk or intoxicated because their brain's not functioning well. And then after that, they can start to slip into a seizure or a coma, and then after that, they don't wake up.
You mentioned before that if the brain is being deprived of glucose, that it can affect the breathing. Is that right?
Correct.
I guess, are there any symptoms you would see with breathing in somebody that is hypoglycemic and blood sugars are dropping?
Yeah, they would no longer be able to take in full deep breaths with their lungs. So where you inhale and exhale, you lose that, the muscles lose that ability to take in those deep breaths. And so you can't draw or pull in oxygen into the lungs. So people will start to breathe very shallowly.
Have you heard of the term death rattle?
I have.
What does that mean to you?
A death rattle, when people are dying and their breathing patterns become irregular, they don't take in deep breaths, and a lot of times they can't move secretions, so you can't swallow. Some of the secretions start getting into the trachea or into the airway, and that can cause an auditory sound that you can hear when people are dying.
Are you familiar with the condition of sleep apnea?
Yes.
What does that mean?
Obstructive sleep apnea often means that when people are sleeping, their breathing patterns will sometimes pause. They either are obstructing, either the tissue is kind of compressing their airway or there's something in their brain that momentarily pauses. Then oxygen levels start to drop. The brain can sense that and it will send a signal all of a sudden to tell the body to take in a deep breath. So sometimes people will gasp awake. So sometimes people are snoring, they'll stop for a few seconds and then they'll kind of will gasp to pull in all that air to correct the hypoxia or the low oxygen levels in the blood.
What you described as a death rattle, is that something consistent with what you might see in a hypoglycemic patient whose sugars are too low that it's starting to affect breathing?
If they've been down long enough that their brainstem is shutting down and they're not taking in deep breaths, then yes, you could hear kind of a death rattle.
Does that sound different than sleep apnea breathing?
Yes.
Would you expect even a layperson to understand the difference between, or hear the difference between those kinds of breathing?
Yes. It is very alarming to hear someone doing a death rattle and not taking in deep breaths in and out.
Would you expect a nurse to understand what a death rattle is?
Yes.
I want to talk about at what point hypoglycemia becomes, well, let me just ask it. At what point does hypoglycemia become a medical emergency?
Really, when your blood sugar starts dropping less than 45, and if it's not intervened upon, that is a medical emergency. So when we have patients admitted in the hospital and they have a low blood sugar, that is a call to the physician to say that this patient just had a low blood sugar, this is what we did to correct it. We will keep checking the blood sugars, but this is not something that is ignored. Also, when we get outpatient labs and someone has a low blood sugar on their electrolyte, their basic metabolic panel, there is a mandatory call from the lab to the physician or the nurse practitioner's office to say, hey, we have a critical alert, is kind of what they call. And so we have to call our patients and say, hey, are you okay? Did you correct your low blood sugar?
Would you expect a trained nurse to know this?
Yes.
Even a nurse that doesn't specialize in endocrinology or hypoglycemia?
Yes, so hypoglycemia is part of their nursing boards. It's part of their normal nursing curriculum. Nurses who treat patients in the clinic, treat patients in the hospital, they know what hypoglycemia is.
I'm going to show you what's already been admitted as States Exhibit 10. It'll maybe take a second, but it'll pop up on your screen right there. And if we could also, since it's been admitted, publish it for the jury. Do you see that on your screen? Sorry,
Yeah,
it
it is.
flickers.
It was fun.
Okay.
Yeah, I can see it.
Do you recognize this?
Yes, I do.
What is this?
This is a spreadsheet of glucose levels and the time that the blood sugars were drawn.
And this is for whom?
This is for Kacee.
Is this something you reviewed in preparation for your testimony in this case?
It is.
All right, I want to go through, and the jury's already heard that we see, oh, sorry, mine just disappeared. Oh, there we go. We see the date, BG level. What do you take that to mean?
So the date is the date that this was, the date that the blood sugars were collected. BG level means blood glucose.
And then do you understand the difference between here, the monitor time and the actual time?
Yes. So you have to set the time on a monitor, just like with old clocks or things that you'd have to set the time and set the date for those to be correct. And so sometimes patients don't set the accurate time.
So is it your understanding in reviewing materials for this case and coming to conclusions, are you relying on, what time are you relying upon?
I was looking at the actual time when I was reviewing this.
All right, I'll start from the top. What's that top blood glucose level that we see?
So top blood sugar is 87, which is a normal blood sugar.
I guess what's the range that you would consider normal in a non-diabetic person?
Normal is typically 80 to 120, but we don't call something as hypoglycemia until it's less than 55 if people are having symptoms. So often a fasting state, you can see blood sugars in the 60s and 70s, and those still are considered to be normal.
The next one down, what's the glucose level?
So 86.
And I'm sorry, let's reference for the record the time. So 87, what time was that taken at?
87 at 9:18.
86 was taken at what time?
10:26.
What's the next one?
77 at 11:16. Do you want to just keep reading them all?
77, so we see a drop from 86 to 77. I'm horrible at math, but that seems to be about 40 minutes? Is that, sorry, 10:26?
Yeah, yes, a little bit. So between the first and the second blood sugar, that's over an hour. And then yes, maybe like 45 minutes is the next. Then the blood sugar checks get a lot more frequent. So 11:55, then 11:59. Those two were collected very close, and that was an 80 and a 79.
Okay, and let me stop you here. So the 86 to the 77, you said that even what's considered normal in a non-diabetic patient can even sometimes get into the 60s. Is that?
That is correct. So
is anything concerning to you about this 86 to a 77, or what does that say to you, that drop?
That's not a significant drop. You can see fluctuations in blood sugars. Oftentimes what we look at in blood sugars is the trend of where they are going. So like if you were to graph this, kind of what that would look like.
Okay, and I'm going to, actually, if you'll indulge me for a second, I'm going to pull up State's Exhibit 10 and put it up in this format. I'm able, so the jury can look at this, and then I'm going to introduce another exhibit with you. If we could pull up just for the witness right now, what's been identified as State's Exhibit 176. Let me know when you see that.
Yes, I can see it.
What, do you recognize this?
Yes.
What is this?
So this is these same numbers but graphed. So on the x-axis, this is the time of day. So you have 9, 10, 11. So hour-long increments. And then on the y-axis, these are blood sugars. So on the left. And these are just taking these numbers that you see in a spreadsheet form and putting it into graph form so you can see at approximately what time the blood sugars were collected and how they trended over time.
Is this something that you created?
It is something I created using Excel. There is no magic to this.
And you use the data taken off of State's Exhibit 10?
Correct.
State moves to admit Exhibit 176.
Mr. Williams,
No objection.
court receives States 176, wish to publish.
Yes, thank you. And I'm sorry. Sorry, just for my own reference, since I can't see that. Okay, so why is it helpful to have it graphed this way in a trend rather than on in this form in Exhibit 10?
This is how we as physicians usually look at blood sugar. So when someone is wearing a continuous glucose monitor or they come in with a glucose meter, these devices will form graphs like this. And so it is helpful to see kind of trend over time what is happening. This tells us a lot when we have patients on insulin, how fast the rate that we see blood sugars fall tell us information about likely, what kind of insulin was used. We gather a lot of information when we're treating patients with diabetes based on looking at these blood sugar trends over time.
All right, turning back to State's Exhibit 10, are you able to see this?
Yes.
Okay. I believe we had covered, I had asked you about the 77 number taken at 11:16, is that right?
Yes.
In the trend in 176, where is that seen?
So dropping down to that 76 is happening in between like 11 and noon. So that's exactly, that would be the 11:16 reading on this chart.
And then the next reading we see is what after that 77?
The next ones are kind of 79. I mean, it looks like 80 on this chart, but 79.
And those were
76.
taken at, so the next one is 80.
Taken very close to noon, so at 11:59.
Okay, so we have an 80 at 11:55 and a 79 at 11:59.
Mm-hmm.
That spike up from 77 back up to 80, is that something normal in a person?
You could potentially see that fluctuation.
Why do fluctuations happen?
Fluctuations happen because there's a lot of things going into when your cells are using and pulling blood sugar out of the blood. So if someone's more active, for instance, you're going to see a little bit of drop. If someone is fasting, sometimes you can see a little bit of a drop. So there can be some normal fluctuations in blood sugars. But again, we like to typically look at trend of where things are going.
All right, so the next one down we see, I believe, is 76. You see that one?
Yes.
What time was that taken?
So the 76 exactly. Sorry if you want the exact numbers. Was it 10:25.
And sorry, is that the monitor time or the actual time?
Oh, sorry. Sorry. It's just kind of far away. It's 12:31.
And then the next one we see is 69 at 12:57. You see that?
Mm-hmm.
What does that drop from 76 to 69 say to you, if anything?
So when I look at this, technically that blood sugar in the 60s is normal, but you can see that if you were to graph this, it is trending down. So even though those blood sugars aren't quite in the hypoglycemia range, they are trending in that direction based on this. You don't see a fluctuation where all of a sudden you have a blood sugar that's 69 and then it bumps back up to 75. You continually see the next blood glucose is lower and lower.
Okay, and let's go to the next one. The next one is after the 69. The next one is what?
64 at 13:19.
Which would be 119.
119, yes.
What level is 64? Is that still considered in the normal level for a non-diabetic?
Technically, for a non-diabetic, that is still considered to be a normal blood sugar. But I will say that this trend, as a physician, if I saw this, would be alarming.
Why would it be alarming?
Because the trajectory of that line is if you don't intervene, eventually you will cross that 55 spot if that trend continues.
So we talked about things that could naturally cause fluctuations in people. I think you said activity and maybe diet.
Yeah, like food status, and then activity is a big thing that will affect normal blood sugars.
Is this trend that we're seeing up until the 64 level, is that something that can be accounted for just based on activity and diet?
It would be unlikely if someone was really, running a marathon or something like that. Sure, you might see blood sugars kind of drift down in this fast pattern.
The next one after 64 is what?
So then there's a 43 at 143.
And
that is officially abnormal hypoglycemia.
And where do we see this in your trend graph?
So you're starting to see that at in between the hours of 1 and 2 o'clock. You will see that blood sugar grafted right above the line 40.
And you said 43 were officially in hypoglycemic.
Yes, officially hypoglycemic.
What kind of symptoms would a person be exhibiting at blood sugar of 43?
So they would be feeling very hungry, they would be feeling very anxious, they would be feeling sweaty, their heart would be beating very fast, and they would start to be getting confused. So maybe having slurred speech, not able to make rational decisions. Maybe if they were trying to walk, they would be stumbling.
The next one that we see down is after 43 is what?
That's a 30, and that is obtained at 2 o'clock.
What physical symptoms might we see in somebody with a blood sugar of 30?
All of those same symptoms that I talked about earlier would still be persisting with 30.
You talked earlier about hypoglycemia getting to a point where people can enter comas.
Yep.
Is that possible at the levels we're at right now, 43 and 30?
Yes. Blood sugars in the 20s and 30s, we get very concerned that someone is going to have a seizure or they're going to pass into a coma.
After 30, the next one we see is what?
Then we see a 29 at 210.
What symptoms would somebody be experiencing at 29?
All of the same symptoms, starting to be very confused, not able to kind of interact appropriately as you would expect them to.
Would a coma be consistent with that, perhaps?
You could start slipping into a coma here, and this often depends on someone's background brain reserve.
Okay, explain that for us.
So if someone is already under the influence of another substance, their brain is going to take a hit from these low blood sugars much earlier than if someone didn't have those substances into their brain. So they're more likely to be more confused, slip into a coma if they have other substances on board.
What types of substances might cause that effect?
So alcohol, benzodiazepines, narcotics or opiates. Those are some of the big ones. Obviously, if any anesthesia or something like that.
What about an antihistamine like promethazine?
That I don't know of off the top of my head.
Okay. The next one we see after 29 is what?
So after 29, you have a 27 at 222.
What physical symptoms are we seeing there?
Probably all the same things that I described here. These are very dangerously low, life-threatening blood sugars.
And we get the next several are kind of in the same range. We get 27. The next few jump up a little bit, 28, 32, 33. Are you seeing that?
I do see that.
What might account for that little jump?
So this is probably a counter-regulatory stress response. So the body knows that this is dangerous, that your body does not like blood sugars like this. And so it will start releasing several other hormones to combat that, including epinephrine from the adrenal glands, cortisol from the adrenal glands, and glucagon from the pancreas. These are all hormones that are trying to mobilize food stores to try to get more glucose back into the blood. So this, what I think is probably her attempt at a counter-regulatory response to try to correct her blood sugar, but there was too much insulin on board for her body to be able to fight that.
The next reading, I forget, did we get back to the 27 at the end before we get to low?
So, no, we didn't, but 27 at 337.
And again, same symptoms that you've described?
Yes.
The next three we see are low. Are you able to tell, based on Plaintiff's Exhibit 10, what low means?
Yeah, so glucose meters always have a limit of how low they can actually measure. So after a certain threshold, they will just read low. Means it's so low that they can no longer detect it.
And do you have any indication about what low means for this particular glucometer?
It's less than 19.
Is that consistent with other glucometers you've worked with?
Yes, often.
The jump from 27 to at least 19 and potentially lower, what does that say to you?
This just means her body was very much struggling. There was not enough glucose in her blood to sustain life anymore.
Was she, well, we know she was still technically alive at this point. How do you explain that?
It's a sustain. So after a certain period of time, your blood sugar will drop to nothing in the blood. But probably before that happens, the brain that's controlling your breathing doesn't have enough glucose to send that message, and so you're going to start building up carbon dioxide in your blood, and you're starting to get oxygen levels that are going to drop, which means other organs are going to start dying.
Once we get to these low measurements, which is 19 or below, what physical symptoms might we see there?
For how long this has been going on, kind of the hours from 2, 3, 4, 5, 6, 7, someone is going to be in a comatose-like state with blood sugars like this for that sustained period of time. Now, if someone has a low blood sugar into the 27, we fix it within 15 minutes, they're going to start feeling a lot better. But this is a long time to have low blood sugars.
We talked before about the process by which somebody tests blood sugar using a glucometer that is a prick. Remember that?
Yes.
I believe you started talking about around, and correct me if I'm wrong, around 43 is where we may start seeing symptoms of confusion, slurred speech, inability to move around as well.
Yes.
Is that fair?
Yes.
At what point would you expect in this chart someone to be unable to physically do the process of testing their own blood sugar? If you're able to say.
Yeah. That drop, when it drops from 43 down to 30, anytime after that, it would be incredibly hard for someone to test their own blood sugar. And I say that because of the time of how long there was already a low blood sugar in the 40s and how much time had passed, that the body is losing its reserve to continue to check. Those people are very confused. When we have patients who have a bad hypoglycemic event, sometimes they actually require third-party interventions. They are so confused, they can't even drink the juice anymore. So they have to have people sometimes give them glucagon shots or something to go up their nose because they are so confused they can actually no longer correct the low blood sugar themselves.
Are you aware of, I guess, whether Kacee was eventually taken to the hospital?
Yes, I know that she was taken to the hospital. I did review those records.
Are you aware of what her blood sugar level was when either EMS or when she was taken to the hospital?
Yes, so from what I recall, when EMS came and they tried to do a blood sugar, it was too low to read, and so they administered her some dextrose. Then I believe when she got to the hospital, her blood sugar was 14 on a serum blood sugar check, and this was after she had already been given dextrose by EMS. Dextrose is a form of sugar, of glucose in a medical kind of, usually there's different concentrations, but it's usually in sterile water, call it D5, but it's dextrose water.
A blood sugar level of 14, is that something that you would expect somebody to come back from?
Not if it had been sustained for a very long period of time, so hours.
You mentioned before that there's short-acting and long-acting insulin.
Yes.
Can you briefly describe those?
Yeah, so long-acting insulin is insulin that when it gets injected into the skin, it forms these microparticles based on pH changes where it will slowly be reabsorbed into the body. So it's meant to last over 24 hours. So for example, I'm just going to pick this number because it's easy math. If someone injects 24 units of a long-acting or basal insulin, that insulin breaks down at a rate of 1 unit per hour. So you have a glob of insulin sitting under the skin, and it releases 1 unit into the body per hour. It's designed to last a long time. And that's for our patients with type 1 diabetes. Everyone's body always needs a background small amount of insulin to help with cell metabolism.
What is short-acting insulin?
So short-acting insulin is designed to be absorbed by the body much faster. So usually it's absorbed within 4 to 5 hours at reasonable doses. Now that changes if you give a big dose of short-acting all at once. It changes the volume of fluid under the skin. Your body can't absorb all of that in the normal 4 to 5 hours. It takes longer for it to process.
Are you aware of how long Kacee was attempting to be treated at the hospital?
Yes, and I'd have to go back and look at the dates, but if I remember correctly, it was something around 3 days or so.
Are you aware of what medical interventions were? You already mentioned dextrose being given at least once. Are you aware of what medical interventions given during that time at the hospital?
Yeah, so they were giving her a lot of what we call amps of D50, which is 25 grams of sugar directed into her blood to try to bring up her blood sugars. But then they noticed that every time they did that, blood sugars might stay high for a little bit, but then they would drop rapidly. So then they started a drip, which just means that someone is constantly getting an infusion into their veins. And so she was started on a D10 drip. Even with that, she was still requiring D5 pushes or these extra glucose to try to bring up her blood sugar. So then the medical staff then increased the concentration of the D5 drip. They moved to a D20 drip, so 20% dextrose to try to keep her blood sugars stable. All this to say is she got a lot of glucose by the medical team trying to stabilize her blood sugars, which tells me that she received a large dose of subcutaneous insulin. So insulin that was injected into the skin.
And let me stop you there. You say large dose. What does that mean for a person that's not diabetic?
So the pharmacokinetics of this, if you inject more than 0.4 units of insulin per kilogram of body weight, it will change, how do I describe this? It changes how long the insulin lasts in the body. And so for her, when I had looked at her body weight in the past, that's roughly about 38 units of insulin. So anything greater than that or a higher amount, you're going to expect her body's going to take longer to metabolize that insulin. It's going to take, as I said, probably days to metabolize that bolus of insulin that went under the skin.
And you said anything greater than 38 units would have this effect?
Yes, and that's based on textbook kind of calculations of insulin per kilogram.
You mentioned that part of your conclusion that she received a large dose of insulin and that it was administered subcutaneously. You may have already described that, but tell us again what that means.
So if we inject insulin into the vein, that's insulin directly into the bloodstream, insulin is rapidly cleared within 5 to 7 minutes of being administered into a blood vessel. But if you inject it into the skin, then that insulin slowly has to break down. Those insulin particles have to move to a vessel to be distributed to the rest of the body. And so that's where different insulins, their onset of action change. It's because how they're designed to break down underneath the skin. If you inject any insulin into a blood vessel, it doesn't matter if it's long-acting, short-acting, regular insulin, it all has the same properties. It's cleared from that blood vessel within 5 to 7 minutes.
Is that true even if given a huge amount?
Yes, even if given a huge amount, you're going to see a rapid drop in blood sugars because that insulin is delivered directly into a vein. So when people get admitted for diabetic ketoacidosis, this is something where patients with type 1 can get really high blood sugar. We administer insulin drips, which they are directly insulin into the vein, where the nurses can titrate the insulin levels based on the blood sugar response. And because you see blood sugars change really quickly in the blood, you can be more precise with the amount of insulin that's being administered. If you administer insulin into the skin, you don't have as much control of how that insulin gets distributed to the body because you're relying on the body's natural, like the skin and the pH in the skin for that insulin to be absorbed and then go into the blood vessels, if that makes sense.
Are you aware of whether Kacee Terry had a port?
Yes, I do know that she had a port.
Briefly describe what a port is.
So a port is, it's a kind of a catheter that goes underneath the skin directly into a major blood vessel. So when patients need, usually we do this for often for chemotherapy. If patients are expected to need to be stuck a lot, they can, if you do too many kind of IVs into peripheral veins, those veins can start to get damaged and they can kind of blow. And so then it's difficult to get people to have access. So often if we anticipate someone's going to need a lot of injections, we will put in a port. So that's something that goes into one of your bigger blood vessels, more in your central body.
Part of your conclusion was that Kacee was administered somehow subcutaneous insulin. How do you know that this was not given through her port?
Because with the port, if the insulin was injected into a port, it would have gone directly into a blood vessel, and so you would have seen that drop within 5 to 7 minutes. So looking at that graph, which has disappeared.
Sorry, can we put back up Exhibit 176?
So based on this, it is based on the rate of change of blood sugars, it is theoretically possible that insulin could have been administered via a port at 119, when you see that rapid drop of a blood sugar that's in the 60s straight down into the 30, that could be subcutaneous insulin, that could be insulin via a port. That's fast. I can't tell you at that particular moment. I could not exclude that it was not put into a port there. But I do know that insulin was not put into the port at 9:20 in the morning or 9:18 in the morning.
And how are you able to make that conclusion?
Because the two blood sugars, that line is pretty flat. I do not see any change in blood sugars at 9:20. So if that was insulin via port, you would have seen rapid blood sugars drop in that hour.
What would you expect to see if given subcutaneously around 9:18? And let's start with if given short-acting insulin around 9:18, what would you expect?
Yeah, so short-acting insulin has an onset time of 15 to 30 minutes. So when you look at this graph, 15 to 30 minutes is happening, and you don't see a blood sugar drop as you would expect. So at 9:18, you would expect within 15 to 30 minutes, so before 10 o'clock, blood sugar would have started to drop based on the onset time of short-acting insulin.
What about this drop from 86 to 77 between 10:26 and 11:16? Are you able to tell anything
Sorry,
about that?
can you repeat the question again? Where do you want me to look?
Sorry, the drop between 86 to 77, the second and the third one.
Sure. That could be normal fluctuations in blood sugar. It's hard to exclude. There could have been a small amount of insulin injected at that time. It's hard because you do see a change there. It's not a huge change. So again, it's hard to say, is this just physiologic variation or was there a small amount of insulin given at that time?
And again, are you able to conclude whether if a small amount of insulin was given at that time, are you able to conclude whether that would be subcutaneous or through a port?
Through those times, let me just look at it again. 10:20. If there was anything given into a port at 10:26, I mean, you would have seen a drop in 5 to 7 minutes. But because it wasn't a huge drop and you see a rebound when you get close to the noon hour, if there was insulin through a port there, it was a teeny tiny amount, if anything.
Okay. And at some point, you say you become very confident that the insulin could not have been given through a port. Where do we see that?
I know insulin could not have been given through a port at the beginning of the mornings of this chart. So like at 9, I know that insulin was not given via a port there because the next blood sugar at 10:26 is about the same as the blood sugar that it was an hour. So if there was insulin given, significant amount of insulin given in a port that would cause hypoglycemia, that blood sugar should be lower based on the onset of action of insulin delivered directly into a vein. Subcutaneous insulin definitely has different properties.
Okay, let's talk about that. What, if any, conclusions are you able to make about timing of when subcutaneous insulin may have been administered?
So if we were talking about Novolog, which is a short-acting insulin, and in my understanding that's the insulin that was found on the scene, So that has an onset time of 15 to 30 minutes. So when you look at these drops, and I look at it as an endocrinologist who's used to looking at blood sugar trends, to me, it looks like short-acting insulin was administered probably around 12 to 12:30 to cause that significant decline that we see in the trend in the graph.
And again, it would, are you able to tell anything about the amount?
I can't tell anything about the amount based on this particular graph. I just can tell you it was a lot of insulin based on the rest of her trajectory of her hospital stay.
Okay, so is it fair to say that Kacee could have received multiple injections throughout the day?
That is possible.
Is it fair to say that she could have received one large injection, which you said would be anything over 38 units for her body type
Yes.
at one point in time?
Yes. So based on this, I cannot exactly say how many injections were given, how much was given at each time. I just know that during this day she was given a large amount of subcutaneous insulin.
How many units, insulin's measured in units, is that fair?
Yes.
How many units are in a vial?
So there are 100 units per ml of insulin, and their vials typically come in 10 mLs. So there's 1,000 units per vial.
Okay, so again, I'm bad at math. So would 1 milliliter equal 100 units?
Yes.
What would you expect 100 units to do in a non-diabetic patient, or not patient, but person of Kacee's
It would
properties?
it would cause significant life-threatening hypoglycemia.
We talked about kind of the treatment or reversible window or optimal, I don't know, I'm putting words in your mouth. I believe you said 15 minutes. If somebody's pretty low, we can reverse it.
Sure.
At what point does it become difficult, if not impossible, to reverse?
So again, everyone's brain is a little different with this, but for most people, I say when you're getting into the hours of prolonged hypoglycemia that is this profound, that is this low, not talking about like mild hypoglycemia, but this low, that's when you're starting to get irreversible brain damage from hypoxia.
And once we're getting into the low readings, be it below 19.
Yeah, that's considered to be very, very low.
Would you expect a trained nurse to know this?
Yes.
If someone is getting these low readings, meaning that their glucose is in the teens, is that a medical emergency?
It is a medical emergency.
Is it the kind of event where even minutes may matter?
Yes.
Would you expect a nurse to know this?
Yes.
Could Kacee have potentially survived if given medical care at some point in this graph?
Yes.
Are you comfortable saying at what point?
The first time intervention, could have certainly saved her life is when you have that true hypoglycemia in the 40s. If that was corrected, that would have saved her life.
So that's at 143?
I would say until you're starting to get into the hours where you're looking at 2 to 3, 3 to 4, that's again when you're going to start getting irreversible brain damage. Now, you still might be able to save someone's life, but they might have cognitive deficits.
Is this trend, or these results that we're seeing with blood sugar, could that be the result of any kind of natural body process or other disease?
There is only 2 things that cause prolonged hypoglycemia in a hospital requiring D10 and D20 drips. One is profound insulin overdose. The second thing is something called an insulinoma, which is a 1 in a million event where someone has a tumor in their pancreas that produces insulin. But we know that she did not have a tumor in her pancreas based on autopsy reports, which leaves insulin overdose.
Sorry, I'm just going over my notes. In your professional medical opinion, was hypoglycemia a substantial factor in the cause of Kacee's death?
Yes.
In your opinion, medical and professional opinion, was the death of Kacee the natural and probable consequence of severe hypoglycemia left untreated?
Yes.